क्या बात है भाई? इंटरनल असेसमेंट आप लोगों का ही था क्या? अभी नहीं हुआ आप लोगों का? ठीक। तो आज का अपना टॉपिक है ओबेसिटी इन चिल्ड्रन। ठीक है, थ्योरेटिकल पॉइंट ऑफ व्यू से ज़्यादा इंपॉर्टेंट है। प्रैक्टिकल के अंदर आपसे पूछा जाएगा मोस्टली। क्रक्स मैं बता देता हूँ, क्योंकि आप लोग मोस्टली इंटरेस्टेड नहीं होंगे, अभी आप लोगों के अदर सब्जेक्ट चल रहे होंगे ENT ऑफ तो, ठीक है। पर ओबेसिटी ऐसा पार्ट है जो मेडिसिन के अंदर भी पूछा जाता है, पीडियाट्रिक्स के अंदर भी पूछा जाता है। आपको BMI निकालना आना चाहिए, हाउ टू कैलकुलेट BMI, व्हाट इज BMI क्लासिफिकेशन, हाउ वी आर गोइंग टू क्लासीफाई अकॉर्डिंग टू BMI फॉर द ओबेसिटी, क्या क्या रेंज है, क्या क्या क्लासिफिकेशंस है, एंड हाउ वी आर गोइंग टू मैनेज द ओबेसिटी फॉर स्पेसिफिकली इन पीडियाट्रिक एज ग्रुप, as this is the more common problem in developed countries instead of developing countries. But because of use of sedentary lifestyle, more watching TVs, screen time and fast food, now it is increasing in developing countries like India also. So what is obesity? Excessive storage of energy as fat related to lean body mass. Body fat expressed as a percentage of body weight, percentage of body fat, the most relevant measurement for the obesity. So how we are measuring? There are different methods, direct and indirect methods. Direct methods, weight in and out of water, dual energy X-ray absorptiometry, USG, CT, MRI and bioelectric impedance. ठीक है, so they are just for theoretical point of view. You must know कि what are the direct measurement. In practically how we are measuring it, it is different. So disadvantage of direct measurement, it's very complex nature, high cost and difficult methodology. Now the practically we are measuring skin fold thickness. ठीक है, it's the practical aspect how we are measuring the obesity for skin fold thickness. So central obesity and peripheral obesity. So centrally we are taking subscapular, suprailiac and mid abdominal, while peripherally we are taking biceps and triceps. Triceps skin fold and biceps skin fold thickness we are taking. So triceps skin fold thickness is most commonly used in pediatrics. More than 85th centile is considered as obesity. More than 95th centile of skin fold thickness is super obesity. The methodological problem hinders uses of epidemiological purpose. Now there are other methods also. Anthropometric measures might be you have been taught in your earlier classes. What is anthropometry? Can anybody tell? What are measures we are taking in anthropometry? किसी ने क्लास अटेंड करी है शुरू की? क्या होती है एंथ्रोपोमेट्री? Anyone? So they are basically very core topics of pediatrics. You must be know about anthropometry. You must know about development, developmental milestones, immunizations, nutritional histories, birth histories, antenatal histories. These are the, I just say ki core topics of pediatrics. You must know when you come in your final. These will be asked in your practical as well as your theory also. So these must be covered. You must know these topics are like the heart of pediatrics. So you must know aware about anthropometry. Anthropometry is basically the growth measurement of a child. So what are the criteria we are taking in it? We are taking weight, we are taking height, we are taking head circumference, we are taking chest circumference. ठीक है? So these measurements, and we are taking whether the child is according to his age or not. So we are plotting these anthropometry on growth charts. So you must be aware in PSM also they are telling you about the growth charts, how to plot a growth of a child on growth charts. So weight for height is also a type of anthropometric measures. Based on NCHS standards, obesity is when we are considering weight for height 90th centile of 120% of median. Super obesity is 95th centile. So may misclassify the child with large body frame or excessive muscle mass. So there is also drawback in this one, like we can misclassify a child who is having larger body frames. So age specific growth charts you must be aware. It is you will be told in your PSM classes also. They will tell you about the growth charts, how to plot a height and weight of a child on the growth charts and interpret that growth chart. Now BMI. BMI is very, very important. It will be asked definitely. One question you will get in your pre-PG exam also. So you must know what is the formula of BMI. It's weight upon height square. Weight must be in kg and height must be in meter square. So most robust and convenient measure of measuring obesity in adult, directly correlate with the risk of medical complications. So what is this? These are CDC growth charts. There are different growth charts we are using. CDC growth charts are internationally recognized. We are having IAP growth charts also, which we are following in India especially. So different growth charts. So we are having different curves are there. The lower one curve are for 5th centile. If we stand 100 students or 100 people in ascending order, then the person who is on the 5th standard will be 5th centile and 95th is 95th centile. So and 50th one indicate the median of that one. So we are taking median as a standard. Anyone who is falling below 10th centile or will be considered abnormal, and above 95th centile will also considered as abnormal. As we earlier told also ki 90th centile means it will be. So these growth charts you must be aware. So we are having different growth charts for the girls and the boys. Now the classification of BMI for the adult we are categorized. If BMI is less than 18.5, we will take it as underweight. Ideal weight is 18.5 to 24.9. Then classification for pre-obese 25 to 29.9. Obese we are classifying in class 1, 2 and 3 as 30 to 34.9, 35 to 39.9 and more than 40. For children, there are certain changes are there. In USA, they are taking 85th centile and above as overweight and 95th centile and above are obese. It is not accepted. Why? Because of largely it is arbitrary and based on data from USA. Means it's taken from the developed countries, not applicable in developing country. BMI like adult cutoff points are linked to BMI centile in the children. Cutoff point determined using values from 6 countries. What are those 6 countries? USA, Netherlands, Brazil, Hong Kong, Singapore and Great Britain. So you can see all of these are from developed countries data. BMI drawback, it is largely based on the data from the developed countries. Undernutrition increases the value of BMI without increase in fat. Stages of genital maturation is confounding interpretation. Now we will conclude for the BMI. It is used as a screening tool to identify the obesity. Overweight, not obese means having high BMI, low skin fold thickness. If child is obese and not overweight, high skin fold thickness, low BMI. Overweight and obese, both the things will be high, BMI and skin fold thickness. Now it is an major problem. Cases are increasing in pediatric age group also. So it is increased by 50% from 1973 to 1974 in USA. So now what are the types of obesity we are looking? So basically it's 2 types, central obesity and peripheral. Centrally means android obesity. Android obesity, fat accumulation in the upper segment. So they are having apple shaped distribution, more likely to develop the complications like hypertension and diabetes mellitus. Waist hip ratio will be more than 0.8. So like this you will get the upper part is having more fat accumulation. Second one is gynecoid obesity, more subcutaneous fat accumulate over the thigh and the lower segment. It's a pear-shaped obesity. Complications are lower. So causes, now we will come for the etiology. It can be classified endogenous causes, which are comprises of genetic and endocrinal causes responsible for less than 10% of cases, should be ruled out before treating the exogenous obesity. So endogenous causes, endocrine and genetic. Endocrine, Cushing syndrome, hypothyroidism, hyperinsulinemia, pseudo-hyperparathyroidism, acquired hypothalamic syndromes. Genetic causes, Prader-Willi syndrome, Elstrom's, Carpenter, Cohen and Lauren-Moon, Biddle-Buddle syndromes. Now, if we will look for the comparison between exogenous and endogenous, endogenous will be having family history very uncommon, while exogenous you will get family history. Endogenous obesity is short height, low IQ, retarded bone growth and physical defect are common. Exogenous obesities, they were tall, normal IQ, normal bone age and normal physical examination. Causes of exogenous obesity is genetic, environmental, dietary, neurochemical and malnutrition. Malnutrition not only included undernutrition, it is having overnutrition also. So the term malnutrition means undernutrition plus overnutrition. Obesity. Genetic causes, strong correlation between the body weight of child and biological parents. Resting energy expenditure genetically determined influences the obesity. A number of genes are showing involved. So basically leptin gene is responsible for obesity causes. So OB genes, product of leptin, which reduces the appetite, increases the metabolic rate, increases the fat oxidation. Mutation results in decreased leptin output, leading to obesity. DB genes regulate leptin binding sites, establish set point. Fat gene produces carboxypeptidase, causes misprocessing of insulin, compete with leptin binding. Tube genes, agouti genes, so there are different genes. Environmental factor in first year, duration of feeding, ages of introduction of the solid food. Second years, the maternal weight reflects the maternal influence of child intake and expenditure. Vigorous feeding, sedentary lifestyle, TV viewing, all these are responsible for causing obesity. Dietary factors, reduces meal frequency, gorging, promote weight gain in contrast to nibbling. High calorie dense food intake. Neurochemical causes, feeding and appetite closely regulate, imbalance may leads to obesity. Factors include insulin, neuropeptide Y, dopamine and other mononucleotide, serotonin and gut hormone like CCK. Malnutrition, prenatal malnutrition predisposed to obesity due to altered development of hypothalamus and sympathetic system. Undernutrition in later life, tendency to accumulate fat more rapidly and intra-abdominally. So this is a viscous cycle for getting the obesity. A healthy child is having sedentary lifestyle, getting mildly obese. Again, the exercise are reduced, he will become more obese, moderately obese, and it will hamper his physical activity, and with sedentary lifestyle he will get severely obese. With severely obese, child will convert into severely obese adult and will going to be having the complications. Complications of obesity: medical, orthopedic, dermatological, psychological and endocrinal causes, complications. So medical complications, child will get the hypertension, hyperlipidemia, coronary heart disease, cholelithiasis, steatohepatitis, respiratory infections, obesity, hypoventilation syndrome and obstructive sleep apnea. So these are the medical complications of obesity. Orthopedic complications, child will going to be having slipped femoral epiphysis, leg cow Parthes disease. All these you will get in your orthopedic class also, ki when they are going to be and what are the causes. So they are mostly associated with obesities. In adult, Blount's disease, slipped femoral epiphysis. Dermatologically, child is going to be having heat rashes, intertrigo, monilial dermatitis, stria, and acanthosis nigricans. Psychological complications, they are most serious consequences. Why? Because they will affect the person's self-esteem. So, lower self-image, heightened self-consciousness, and impaired social functioning. Negative stereotypic arbitrary by peer groups and even trained physicians, less likely to be successful in life. Endocrinal complications, hyperinsulinemia with insulin resistance, over diabetes, stimulate lipogenesis and maintain the obesity, hyperplasia and hypertrophy of fat cells. So, now how we will evaluate a child of obesity? First, you have to, very important, history, physical examination and laboratorical examination. So, for history, you have to be asked duration of the disease, previous attempt at weight reduction, whether child is having any attempt for weight reduction. Daily calorie intake you have to calculate and expenditure, family history for attitude and practice, weight status of parents and siblings, meal pattern and recreation habits. Family history of any CSD, congenital heart disease, cancers, diabetes, hypertension, hyperlipidemia or thyroid disorder to rule out genetic causes for obesity. History of complications, psychosocial history and its evaluation. Physical examination, you have to assess the growth, distribution of fat, which type of obesity child is having, either gynecoid or android. SMR staging is very important. Blood pressure and other clinical examination. Laboratorically, you have to be take the hormonal studies for pituitary, adrenal and thyroid, blood glucose and insulin levels, plasma lipid levels, serum cholesterol levels. Now, management, how we are going to manage, very important. The goal of management to achieve lifelong weight control, avoid weight cycling, maintain normal growth, metabolic safe, minimum hunger, preserve lean body mass and no psychologically problems. So, very important algorithm, from 2 to 7 years of age group, if BMI is between 85 to 94th centile, you have to maintain the weight. If BMI is more than 95th centile, without complication also, you have to only maintain the weight. But if complications are there, then you must have to lose the weight. Your target should be weight loss. More than 7 years, if BMI is from 85 to 94th centile, without complication, you have to weight maintain. But if more than 95th centile BMI is there, then you must go for weight loss. So, what is our goal? In most of the children, goal can be attained by just maintaining the weight. In more obese child, achieving the weight loss, not vigorous, only 0.5 kg per week. Vigorous weight reduction is also going to be having problem with the child. So, your target should be weight loss from 0.5 kg, half kg in 1 week. Dietary management, diet must be provided all essential nutrition. Calculate calorie intake on principle of 0.5 kg of weight loss, means 3500 kilocalorie deficit, means the required calorie for the child, you must be having deficit of 3500 kilocalorie. Limited duration of bottle feeding, replace fat with complex carbohydrate. In diet, you must include complex carbohydrate instead of fat. Increase the fiber intake. The formula for fiber, how much fiber child must take, is calculated from age plus 5 to 10 gram per day. Special diet, balanced hypocaloric diet. Provide 30 to 40% less than usual intake with lower fat. Fat should be only 25 to 30%. More complex carbohydrate. Total calorie, the carbohydrate should be having 50 to 55% and sufficient protein intake. Ensure normal growth with a weight loss of 0.5 kg per week. Special diet, the restricted protein sparing modified fast diet, provide only 600 to 800 kilocalorie per day, having 1.5 to 2 gram per kg protein, 2 liter of water, and 2 to 4 cups of low starch vegetable. Achieve faster weight loss. More specific side effect, as I told you, we are going to be having the